We get that question a lot. Patient coming in with very severe pain. Usually the concern is that we have to get to the bottom of what's causing their pain. Okay, we have to find out what the pain generator is to be able to then help the patient. And usually we always are able to identify the pain generator and then target that with a multimodal treatment approach to get the patient feeling better. We try to do that where the patient can start feeling better a lot in a fast manner, so that they can start getting back to what they like to do. It's really a good question. Again, one of the things when we get a patient like that, we would like to make sure that we kind of review what treatments they've had before. Again, like I stated, because there's something called surgery, and because I'm a surgeon, doesn't mean that that patient will require surgery. We have a lot of patients coming in for a second opinion or third opinion that are already on a surgical schedule elsewhere. After we assess them and set up a treatment plan for them that involves non-surgical treatment options, their symptom actually goes away, so they avoid to have surgery. So we have a lot of patients coming in that are actually indicated for surgery. Doesn't mean they cannot have surgery and do well with the surgery, but we try to advise the patient on their options, reminding them that surgery is a last resort, trying to get them an effective treatment protocol. Some of them will involve treatments they've had before, but do it in a manner that will hopefully maximize the ability to get a very good symptomatic resolution. And a lot of times we achieve that goal, where that patient actually who was on a surgical schedule somewhere else, or who have clearly symptomatic surgical pathologies, become asymptomatic, and they get to avoid surgery that they probably would have had had they not exhausted appropriate conservative treatments. And these treatments are not something that is going to last for months and months and months. Okay, putting together a good multimodal conservative treatment option usually takes about a few weeks to complete, and usually we advise patients to, again, try to stay conservative and think about surgery as a last resort, because I always try to say there's nothing surgery cannot make worse. It doesn't matter how bad your problem is, it doesn't matter how bad your condition is, it doesn't matter how bad your limitations are. There's nothing surgery cannot make worse. Okay, it's very, very important to understand that, and to understand that surgery changes your anatomy permanently. Okay, you cannot reverse that after you've had surgery. Obviously, the less invasive treatment options you have, you do a minimally invasive procedures, those disrupt the anatomy less. But every kind of surgery alters your anatomy forever. So you don't want to get into doing that until you're sure that you've exhausted the appropriate conservative treatments, okay, and you continue to have ongoing symptoms. It's very, very important to understand that. I like to tell patients that minimally invasive surgery is maximally invasive surgery if somebody does a minimally invasive surgery when they could have gotten better without surgery. So we always like to mention that to patients. We have a lot of patients coming in with surgical pathologies, as we talked about, and already on the surgical schedule elsewhere. It's important to understand that because someone can go and do a surgery to remove this herniated disc, that if that patient could have had symptom resolution within 6 weeks without surgery, with the right mixture of conservative treatments, and they go ahead and have minimally invasive surgery, that surgery is technically indicated. So it's clearly indicated, but that patient, minimally invasive surgery in that case could have been avoided.